Welcome everyone to our BJJ podcast for the month of March. I am Andrew Duckworth and a warm welcome from your team here at the Bone and Joint Journal. As always, we'd like to thank our readers and listeners for the comments and support we receive, as well as to our many authors and guest interviewers who have taken part so far. Over this year, we hope to continue to build on the range of topics we've covered through our series so far, with our continuing aim to improve the accessibility and visibility of the studies we publish for both you as our readers and listeners, as well as for our many authors. For this month's study, as you know, over the next 15 to 20 minutes or so, we will cover a range of aspects for the chosen work, emphasizing the important points of how the study has been designed, as well as the key findings from the data and how these potentially fit into each of your day-to-day clinical practices. We also hope to give you a behind-the-scenes insight into how the authors have developed the study and give them an opportunity to put forward the key findings of their work. So today I have the pleasure of being joined by Mr Paul Jenkins from Glasgow Royal Infirmary to discuss their study entitled The Changing Incidence of Arthroscopic Subacromial Decompression in Scotland, which has been published in the March edition of the BJJ. Welcome, Paul, and a big thank you for taking the time to join us today.
Thank you very much, Andrew, for the invite to take part in this podcast.
So, Paul, if the aim of your study was to examine the recent trends in delivery of arthroscopic subacromial decompression in Scotland, and to determine if this varies by geographical location throughout the country. So can you give us a brief introduction to the paper and some background to the recent studies highlighting the chronic tendinopathic model of dysfunction for subacromial pain?
So I think, as you say, this paper was rooted very much in the emerging concepts of the pathogenesis of tendinopathy, affecting the whole broad spectrum of tendinopathy throughout the body. In the initial sort of evolution of tendinopathy, it was sort of first described really around the shoulder by Codman in the 1930s as a result of intrinsic degeneration inside the tendon. And it was really only later on that Neer described the extrinsic model and coining the term impingement, with impingement of structures such as the sort of hooked aspect of the acromion and the CA ligament, leading to rubbing and damage. And it was these concepts that then led to the surgical management by taking them away, first with open procedures and then with the advent of arthroscopy. And the advent of arthroscopy was very seductive in that you could take a procedure which was associated with reasonable morbidity in terms of its open setting and undertake it with a very small incision and a much lower morbidity associated with that. On the back of that, we definitely saw a really rapid expansion in the adoption of subacromial decompression as a technique, and that was described by Professor Carr and his group in a paper in the Bone and Joint Journal in 2014, which described the temporal trends and geographical variations in England over a period of 2001 to 2010. And they reported a sevenfold increase from 5.2 per 100,000 to just over 40 per 100,000. Following on from that, there were two really quite influential, large, prospective, pragmatic, multi-centre randomised controlled trials. The first was UK-based, which was the Seesaw study, Can Shoulder Arthroscopy Work, undertaken again by Professor Carr's group as the chief investigator and published in The Lancet in 2018, but had been published online the previous year. And similarly, there was a study from Finland from Pavola et al. In the BMJ, which looked with quite a similar study design. The Seesaw study randomized patients into three groups. The first was no intervention at all, and then there were two surgical groups. The first surgical group was shoulder arthroscopy alone, which was designed as a placebo intervention group, although I think we have to remember that in that group, patients did undergo a diagnostic arthroscopy, and both the joint and the bursa were instrumented and had saline insufflation. And I think, as many of the listeners would agree, it can often be very difficult to see at all in the bursa without removal of at least a little bit of the bursa, and therefore possibly a partial bursectomy. And these are points which can be discussed in terms of how we interpret the results. The Seesaw study showed that both diagnostic arthroscopy alone and the actual full subacromial decompression with removal of these hypothetical extrinsic compression structures were both superior to no intervention in terms of the study endpoints of the Oxford Shoulder Score, but that there was really equivalence between them in terms of their efficacy, and the conclusion was that the placebo surgery group was as effective as the actual surgery group. The FIMPACT study was slightly different in that patients were initially randomized to either physiotherapy or surgery, and then within the surgery group they were randomized a second time into the sort of placebo diagnostic arthroscopy group or the arthroscopic subacromial decompression group. Both these studies really started to be widely discussed amongst the shoulder community, and along with the evolving concepts of the pathogenesis of tendinopathy as being not a purely extrinsic issue, led the shoulder community to start to really think about the indications again for subacromial decompression and where it was used. And we wanted to look at a national database to see, was there an improvement in, or was there a change in the provision of this procedure around the time that these studies started to be published.
That's a great overview, Paul. And I think just it sort of brings together sort of the background to an SAD and also the recent studies. And I think, like you say, your work's very timely in determining, certainly in Scotland, how the literature has influenced that. So if we move on to how you performed the study, you analysed national temporal trends in procedures utilising the National Scottish Mobility Records, or SMR, for the period between March 2014 to April 2018. So for our listeners, Paul, some who won't be familiar with the SMR, what does that database normally collect, and sort of how robust or how accurate is it?
Well, this database has been run for a long time, stretching back to the early 1980s, and it's run centrally by the NHS Scotland Information and Statistics Division, and every episode within Scottish hospitals, either in the day case or an inpatient, generates an SMR01 code, and SMR stands for the Scottish Morbidity Record, and this is very similar to the English HES type data. The data is generated by hospital coders who at the end of an episode will look through the immediate and final discharge letters along with the operation notes and any other information in the patient's notes to make a code about the underlying diagnosis with the ICD-10 and the procedure undertaken with the OPCS code. It's a very useful data set, and in other settings, because of the use of the Community Health Index number, which is unique to every patient, we can also look at sort of linkage studies and look at linkage to other national databases. But this was a relatively simple and straightforward query we asked of the database, just looking at one sort of set of procedures over a period of time. In terms of its accuracy, there have been studies about the accuracy, and it has been reported as being in the region of 90 to 94% when it has been validated. With any of these sort of databases, however, we have to accept that there will be a degree of miscoding. That was one of the reasons in terms of the time periods we chose, because earlier versions of the OPCS coding system had been there was less clarity about the coding of subacromial decompression, whereas from 2014 onwards, there were specific codes relating to that as a procedure. And that was also, again, one of the reasons we didn't look at sort of longer term trends prior to that. Just we felt that it would be introducing some more potential for sort of variation that we couldn't take account of. Also, in terms of if there were going to be some errors in coding, which we would accept, we have assumed that they would be consistent during the period of time. And so we're looking at this in terms of internal consistency, and we would have some slight more cautions when extrapolating it to other work. Although it is interesting to note that the incidence of subacromial decompression at the start of ours was in the same region as 40 per 100,000, as had been described at the end of Professor Carr's study in England in 2014. So I think that actually is quite a nice way of linking those two studies and looking towards the validity of both these data sets.
No, I totally agree, Paul. I think that's right. And I think the accuracy of it is quite clear there. And like you say, with using big data like this, there may be some inconsistencies there, but they're likely going to cancel themselves out over time. And I think before we move on to the results, though, just for our listeners, what were the inclusion and exclusion criteria you had for the study in particular?
So we looked at, in general, we looked at patients who had the specific codes of arthroscopic subacromial decompression. And then we were looking at those who had had an arthroscopic AC joint excision alongside that. We excluded any open forms of AC joint excision because one suggested hypothesis was that as the ability or the subacromial decompression became a sort of less common procedure, surgeons may look to treat other pathology of questionable symptomatology. You know, in some cases the AC joint is very much symptomatic, but in other cases there may be radiological changes, but it's not providing sort of symptomatic cause. So we wanted to look at this as a balancing measure to see, you know, what was the rate of other arthroscopic shoulder procedures changing over that same time period.
No, absolutely. And I think that's very clear in terms of, I think the exclusion criteria, like you say, just add to the validity of the way you've performed the study. I think that's very clear. So in terms of, if we move onto the results, shall we say, so what were the key findings? You sort of alluded to what it was like at the start, but what would you feel the key findings are of your study in relation to the number of ASDs performed over the study period and how that changed?
I think the key finding was that the rate fell by approximately 35%, and that the majority of this fall was seen in the year 2018. These were financial years. So that would actually be from April 2017 to March 2018. That fall fell from 41.6 per 100,000 to 28.9 per 100,000. That again validates our hypothesis that some of this fall was due to the ongoing work around tendinopathy in these multi-center randomized controlled trials. Now, one issue that was brought up during the review process was in terms of the timing of the publication of the RCTs versus what we have observed as this fall. Although we have the dates of publication of these RCTs as 2018, they were being discussed, and in some cases were discussed in the wider media and in papers such as The Guardian well before that. And quite a lot of surgeons who had been involved in the process and had actually randomized patients were starting to get a feel for the fact that there may well be sort of limitations of the subacromial decompression. So the feeling was that even prior to the publication of the results, there was an increasing awareness in the shoulder community of the possible outcomes of the study. And I think actually there was an anticipation, and practice did start to change in the year before that.
No, I think that's right, Paul. And I mean, certainly that was similar for, as we all know, for the DRAS study that looked at wrist fractures. The change that started to occur before the study was published, but for those very reasons you just described, you often get that change happening a little bit before the actual official publication date for those reasons. So we talked about the reduction, but in terms of the geographical variations across Scotland, did you see anything when you looked at that, Paul?
This again was very interesting, and it did actually again back up some of the work that had been done by Prof. Carr in the 2014 paper, where we saw quite significant variation between boards throughout the country. In the year 2017 to 2018, of the 14 boards in Scotland, there were 4 where the rate of subacromial decompression was over 3 standard deviations from the national average, and there were 2 where the rate was below that national average. When we look at the sort of numbers involved, some of this could be down to the practice of perhaps 1 or 2 different surgeons or a unit. And in terms of the actual criteria that people use to decide whether to recommend to a patient whether to undertake subacromial decompression or not. There can be variation in terms of the amount of time, the number of steroid injections, the amount of physiotherapy that should be undertaken prior to that. We would plan to use this sort of data separately to feed back to the individual board areas, and it is an area of interest for future research to see whether these outlying areas do come within a more sort of national average and within the funnel plot once that is fed back. Obviously, there are also areas of good practice on show here, but you also have to balance that in terms of when a rate is very low, is there actually restriction in terms of an effective procedure? And I think in all of our discussion, we have to realise that there still is a role for this procedure, and that the danger of some of these studies and some of this work can be for a very binary approach to the problem, where we say this operation doesn't work, it shouldn't be offered. And even when we look back at the CSOS study, there was approximately 25% of the non-operative group who crossed over into an operative intervention over the study time period. So I think we do need a more nuanced approach, and to recommend that it is still there possibly, but as a procedure that may be beneficial, but when conservative measures are exhausted after a reasonable amount of time.
No, I completely agree, Paul. I think that's a key for many of these trials, is that we sort of want a binary outcome and a one-size-fits-all sort of answer to it. But often, I don't think I think you're right. I don't think you can do that. I think it's for more generalizability, and also, I think in this case, as you say, it's sort of saying that this is a procedure we're probably overdoing, but there are a small number of patients who will still benefit from this once they fit certain criteria. So that sort of moves us on nicely, Paul. If you had to summarise, what do you feel the key findings of the work are? And I suppose you've already discussed it briefly, but sort of with any caveats, with any limitations of the data.
I think if we start with the caveats, this looks at sort of large national level data. There is a potential for the data being slightly erroneous or incomplete, although we are sort of reassured by the published validity or validation studies of the data sets being in the region of the 90%, and we're relatively comfortable that the trends over time will be valid in terms of any errors will be consistent over time, because there hasn't been any significant changes to the coding during this time period or the overall methodology. What we don't have access to is the number of these procedures that are undertaken in the private sector. We would actually see that's one of the potential benefits of undertaking this study in Scotland. In Scotland, the private sector really makes up quite a low proportion of the overall orthopaedic procedures done within the country on an annual basis, and I think it makes it probably more applicable or comparable to the national population, although it would be of interest what is happening in other sectors.
Absolutely. In terms of Paul, we've already discussed it a little bit, but you mentioned the greatest decline was seen 2017 to 2018. We think that's potentially related to the literature and sort of the lag time with publication. We've talked about that. But what do you feel the explanations are in terms of the variations you saw across Scotland? Do you think are those variations seen elsewhere in other parts of the literature, and do you have any sort of explanations for that in particular?
I think we see this sort of variation really throughout the literature, and when we look at things like the English Atlas of Variation or the NHS Scotland Atlas of Variation, we see such unexplained variation in the provision of a variety of procedures and other forms of healthcare, from arthroplasty to cataract surgery. And understanding this variation is probably key to trying to improve the provision of healthcare really throughout systems as large as the National Health Service, and trying to filter down the recommendations and getting evidence-based medicine into practice is the challenge, in that there are a lot of studies coming out like this, and trying to get them down to the actual people who are undertaking the procedures and to effect change is probably one of the most challenging aspects of our sort of practice and evidence-based medicine now going forward.
No, I totally agree, Paul. I think, and sort of when you talk about going forward, with relating to your study, how do you feel that the data of these types of studies that sort of reflect on what our practices are on a national level, how do you best move them forward? How can you utilize them to sort of influence our day-to-day individual practices?
I think, as static pieces of work, these are interesting, but I think there needs to be ongoing audit and review and feedback to surgical teams, whether it is through, so we have access to sort of national tools such as the National Joint Registry or the Scottish Arthroplasty Project when it comes to arthroplasty. I think we need to have extension of these projects to cover non-arthroplasty surgery, because actually there is probably the majority of procedures undertaken in orthopedics are actually not arthroplasty related, and I think focus needs to come to them so that we can look at where variation exists to try and understand that and reduce it.
No, I totally agree, Paul. I think that's exactly right. So, Paul, I think that's all we have time for, actually. So thank you so much for taking the time to join us today, and congratulations on an excellent study that I think is without doubt an invaluable addition to the literature in this area. And again, thanks for taking the time to join us.
Thanks again for the invite. It was a pleasure to join you.
And to our listeners, we do hope you've enjoyed joining us today, and we encourage you to share your thoughts and comments through Twitter, Facebook and the like. Feel free to post or tweet about anything we have discussed here today, and thanks again for joining us.